Maria, we can start. It's 7 o'clock.
Okay. Hello, everyone. Good morning, good afternoon, good evening, whenever you are in the world. Welcome to our online conference today. Before giving the floor to our dear guest, I want to introduce our team. I'm Mariam Natslishvili from my side. I'm fifth-year medical student in Georgia at New Vision University. I'm interested in neurosciences, neurosurgery, and everything associated with neuro. So it's a big pleasure for me that I'm moderator today's session, and thanks to Dr. Hassan who gave me that chance. These online education meetings have started with Professor Hasan Kamisucu, the residency program director of the neurosurgery department of İzmir Atatürk Training and Research Hospital in Turkey, and goes on with the contribution to all of the residents. Also, with the contributions of the neurosurgeons who graduated from the same department, also neurosurgeons and neurosurgery residents from nearby countries such as Bulgaria and Georgia. To say a little bit about our rules for today's conference and what we have commonly, all the microphones will keep turned off during the presentation of the lecturer to avoid voice and noise pollution. You can ask your questions by writing to the chat part of the Zoom program, which we have. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for our format. Please don't ask your microphone to be turned on. At the end of the meeting, we will give you the chance if you have the wish, of course. Okay, I will go to the part of introducing our speaker today. Abuzer Güngör is an experienced neurosurgeon who pursued his specialization in neurosurgery at Bakırköy Psychiatric and Neurological Diseases Hospital, Neurosurgery Department in Istanbul, Turkey. During this time, Dr. Güngör also had the opportunity to work as a researcher at several renowned institutions, including Serafasa Faculty of Medicine with Professor Tan Over, if I'm pronouncing probably, Institute of Neurological Sciences, Department of Neurosurgery, University of Florida. To say further, Abuzer Güngör published more than 50 papers, has received many awards for his research. He won the award for Best Thesis of the Year twice, the Best Presentation of the Year multiple times, and organized numerous congresses, meetings. His articles have appeared on the cover of several journals 5 times. He also described various surgical methods and has authored numerous widely cited pioneering academic papers published in international journals. Dr. Güngör has left a lasting impact worldwide through the innovative and advanced academic works he has published. He has also held teaching positions at Acıbadem University and Yeditepe University. He's currently serving as the director of the Microsurgical Neuroanatomy Laboratory funded by Güngör at Yeditepe University. And today we will have such kind of discussion which is associated with that microsurgical neuroanatomy and neurosurgery specialist at Bakırköy Psychiatric Hospital. Dr. Abuzer continues the legacy of Albert Rotan, Gazi Yasargil, and Güngör, whom he sees as his mentors and members of Rotan Society. And he's also part of International Academy of Neurosurgical Anatomy, IANS, Turkish Neurosurgery Associations. And we will see his presentation now. Doctor, can you share your screen now? Okay, please, can we test if other slides are also visible? And if you can go through easily, I mean, to next slides. Can you go to next slides? His voice is not.
You can turn on your microphone. Okay.
Okay.
Sorry for this. Okay. Good.
Everything is okay. Yes, doctor.
Yes, I think. Is there any problem?
No, everything is okay.
Okay. And I want to thank to Hasan Kamil Sucu and his team and the Mervam for the kind invitation. I want to talk about the supracerebellar approach, and it is Wazans. I know it is an international meeting. I want to thank all countries who help us in our earthquake disaster. Most of the countries came and helped us and rescued a lot of people. I have a conflict of interest, but I have a big team behind me, and also in Yeditepe and the Güngör. The data used in this presentation collected via our articles and Wotan collection and our cases. What I want to say, its variance also in supracerebellar approach, with opening the tentorium, you can reach the supratentorial structures, and also you can change your angle. As you see, this is the median, paramedian, lateral, and extreme lateral variance you can use. What can change in this kind of approach? As you see, this is the midline approach. It is close, but it is not direct. You couldn't have a direct angle to the pineal. But when you go to the lateral, you have a direct angle to the pineal, but it's a bit longer way than the midline. And also to describe the paramedian approach, to use the midline and the paramedian. It's a combination of these two approaches. And most of the supracerebellar approach being performed for the pineal gland. As you see, the tentorium was removed. These surgeries can be done. Most of the surgeries also can be done the posterior in occipital, posterior interhemispheric way. But today we talk about the supracerebellar way. I always prefer supracerebellar way if the tentorial angle allow me, because of when posterior interhemispheric approach, occipital lobe and the visual areas can be injured. Because of this, if I can approach via supracerebellar way, I prefer supracerebellar way. Which structures we can reach via supracerebellar approach? As you see, pineal gland, superior colliculus, inferior colliculus, trochlear, also trochlear schwannomas. But when you go down, it is better to a lateral approach because of the Kuhlmann and the Vermes. And also you can reach the lesions located in the brainstem and the third ventricle. Also you can reach the suprapineal approach and the tentorial surface of the cerebellum, pulvinar, the posterior part of the thalamus, and the P2 and P3 branch of posterior cerebral artery, and mesial temporal region, and the tentorium and the petroclival region. And this is a 3D model done in our lab. You can see the structures in the pineal, superior colliculus, inferior colliculus, and you can see the atrium. When you open the atrium, you can see the thalamus. Also, we can reach the upper surface, temporal surface of the cerebellum, ambient cistern, and also mesial temporal region via this approach. And when we look with the vascular structure, you can see the galenic venous systems and the P2 branch. And this is the galenic venous system and the P2 branch. And our opening the tentorium, you can reach the parahippocampal gyrus and mesial temporal gyrus. We are looking from the superior. You can see the hippocampus. After opening the tentorium, you can reach these structures and you remove lesions located in this area. Also, P2 and P3 branch of the posterior cerebral artery. We are looking from the posterior. After opening the supracerebellar area, you can see the Bergh veins, and sometimes you can see the deep-seated Bergh veins. I always try to preserve all Bergh veins in any surgeries, not in only supracerebellar approach, also in interspheric approach. I try to preserve all of these veins. We are looking from the superior. As you see, this is the venous legs and which vein come to. And when we go deeper, we can see the structure, pineal gland, splenium, and the third ventricle. As you see, the basal vein, internal cerebral vein, and the tentorium. And when we look from a bit lateral way, it is better to see the pineal, superior cortical, inferior cortical. And when we open the tentorium, you can see the parahippocampal gyrus, P2 branch. And also, you can use endoscope. Some authors describe endoscopic approach, but I prefer endoscopy assisted surgery. I control the surgical area after removal. And positioning in supracerebellar approach is still a challenging issue. Positioning in the patient is a crucial step in neurosurgical procedures. It must be about the patient safety. You must think the patient safety, surgeon's comfort, optimal trajectory, using gravity, avoiding retraction, and drainage. In supracerebellar atrophy, you can use prone, sitting, semi-sitting, and which we describe the lateral semi-sitting position. If prone position, patient safety is higher, but you may need a retraction. In sitting position, you use gravity and you can avoid the retraction, but patient safety, because of the venous embolism and pneumocephalus, it can be a problem for the patients. And also this approach is not very comfortable for the surgeons. Also, semi-sitting position can be lower the venous embolism, but still you have this risk. And we describe the lateral semi-sitting position. We can change our angle during the operation. I will explain later. And this is a prone position. I always use one-sided craniotomy, also left side, and not all the open the midline craniotomy. I always use paramedian or lateral craniotomy to reach all these structures. And also this is a semi-sitting position. But you must have a good anesthesiology team for this kind of approach. And it is our position, which we it's accepted in operative neurosurgery. This is lateral, dynamic lateral semi-sitting position. As you see, we start with this angle while opening, and after opening the dura, with control all the and after doing all hemostasis, we change the angle to gain the same angle as sitting position. As you see, this is similar as the sitting position, and we use gravity and the drainage of the hematoma and other things. after removal of the tumor, just before the closing, we change the angle again to avoid the pneumocephalus. This is a small video to describe. It is similar to our position we use for contralateral brainstem tumor. As you see, we can change the angle if there is any problem can occur. We follow our patients with antidal carbon dioxide, and recently we described a bit different position. As you see, semilateral semi-sting, dynamic, also dynamic semilateral semi-sting position. I will show the case later. And also this is 3D models of the supracerebellar area. You can see the bridging veins, and also sometimes you can see this is a variation of the sagittal and its transverse sinus. Most of the time I use a one-sided craniotomy, and I always open the superior to the transverse sinus to retract the sinus superiorly. And also the you can see the tentorial veins there. We put a light to show them. And I will show the structure which we can reach via supracerebellar approach. The tentorium was removed, and you can see all structures also via. We can reach up after opening the tentorium parahippocampal region and the mesial temporal structures, and also we can reach pineal gland. As I said, most of the this approach using to reach pineal gland, superior colliculus, inferior colliculus. As you see, when we go to midline, it is a bit difficult to reach the midline structures. And also we can reach ambient system and the structure inside it, like P2. And also with suprapineal way, you can reach the third ventricle and pulmonary. And also with you can reach contralateral way. Because of I always look the dominance of the transverse sinus. If one side is dominant, I choose the other side to enter. And also for the thalamic tumors, also we can use contralateral approach to better exposure. We have better exposure. And I will show some illustrative cases. One thalamic cavernoma. The 20 years old male came with headache, right-side hemiparesis. The cavernoma located in the pulvinar. We use the dynamic semi-sitting, lateral semi-sitting position. As I always put Bergh holes just above the transverse sinus, then made a craniotomy. You see the transverse sinus. We always control all the trajectory of these. Before the opening the our dura, we always release CSF from cisterna magna. As I said before, I always try to preserve all the bridging veins, dissect and gain a better exposure. And we try to reach the pulvinar. Also, you can use the navigation. It's important also navigation with this kind of tumor. We corrected ourselves and evacuate the hematoma, then the cavernoma. Also, in this kind of lesions, you can open the tentorium to get a better exposure. But in this case, we didn't require to open the tentorium. And as you see, the vein is protected and postoperative. And a midbrain cavernous malformation for 2 years old female, with imbalance and tendon gait. And we decided to go lateral mesencephalic sulcus, as always, the bridging veins, and we dissected from the cerebellar surface and the temporal surface. Then we detach all attachments. And we are describing those structures. Also, we saw the fourth nerve and colliculus. Then describe the lateral mesencephalic sulcus to remove these cavernoma without using the bipolar coagulation. And you will see our entrance only 5 millimeter or lesser. And most of the surgeons use this approach for pineal tumors. Sometimes you can be lucky and without seeing any bridging veins, you can reach directly the pineal gland. When there's no bridging veins, I think it will be 5 minutes to reach the pineal. And if you see pineal, you want to reach this area, but a bit paramedian way, as you see. After opening the arachnoid, we are seeing the pineal tumor. And I always check with endoscope to see any residue. And this is the young man with headache, and incidentally detected P2 aneurysm. And we decided to make a surgery. And always I made incision parallel to the transverse sinus. And for this kind of lesions, it is required to open the tentorium. While opening the tentorium, first you must describe the fourth nerve to avoid its damage. We are trying to reach this area, amnion system and the branch of P2. And first we see proximal of the aneurysm and puncture it and put clips and removing the temporal clip and if required. you can put the additional clip. I think it is a 10 centimeter deeper, but it's possible to reach and clip this kind of aneurysms. This is the post-operative angiography show the and also, as I said, the tentorial surface of the cerebellar tumor, you can reach for cerebellar approach. If it is attached to the tentorium or close to the tentorium. And as I said before, for sometimes you can use contralateral approach, depends on the dominance of the transverse sinus. You can see the cavernoma and after removal. And we lastly did this tumor last week. A cerebellar tumor. As you see, there is no cortical tissue between the tentorium and the cerebellum. We use dynamic semilateral semi-sitting position for this approach, and our 3D models, our incision, we use navigation for this kind of tumor to localize the sinuses. As always, we make Bergh above the transverse sinus and make a craniotomy. Firstly, describe the location of the tumor. You can see the tentorium and the tumor opening the cisterna magna. But in cerebellar tumors, even if you release the CSF because of the edema, it can be difficult to reach the supracerebellar space, but it's not impossible. As you will see, we reach the tumor and start the removal of cystic component. And we are removing all parts of the tumor. And also we will control with ultrasound. You can see we preserve these cortical tissue, and the post-operative ultrasound shows no residue. Is the post-operative MRI. And this is our laboratory. All these job done in this laboratory, in this kind of laboratory. I always use these cadavers before operations and check myself again. This is our medical illustrator, Eileen, and these workstations. In Yeditepe University. And also you have postdoc in Yasargil Stein. To the model of our laboratory. I want to thank our team, and I want to invite you the Afterward Istanbul Yasargil Microsurgical and Third International Rotom Society meeting, which held in August in Istanbul. Thank you very much for your listening.
Mariam. You can turn on your microphone. You can turn on.
Thanks, Professor Abuzer, for interesting presentation. I also saw your publications and it was really so interesting. So I want to tell to auditorium, if you have any kind of questions, you can write in the chat, or if you want any of you to comment or speak out, let us know. And of course, we will allow you to speak directly with lecturer. We are waiting for your, okay. Abdullah Emre Taglizi is writing excellent presentation and excellent cases. Thank you very much. You can also write down your university or hospital where you are working or studying, and I can announce that as well. So before other people will write the questions, I will go first. I will have that pleasure. Doctor, I saw your publication about preoperative management. And also I read many things about that kind of approach, and I saw that this preoperative management is really so important step before operating the patient, and for rehabilitation it has also big impact and big effect. So can you tell us a little bit deeply about preoperative management? I mean what? The preoperative management, if we want to do those steps, what kind of complications we get? And if we will go through all of the steps, what kind of impact we will get during the rehabilitation process? This will be our first question, I guess.
Yes, if you for this kind of approach, if you use semi-sitting position, sitting position, and in our position, lateral semi-sitting position, the patients must be examined from a cardiologist and get echocardiography to show any cardiac shunt, because it is a contraindication for the sitting or semi-sitting position. And also you can use anti-edema treatment for tumors with edema. I think this is my tricks for this kind of patient.
Okay, Mariam.
I think doctor is searching for case or not. Okay. Okay, so one of the question is, 1 minute, yes. Jeremy is writing the question. Do you routinely use a lumbar drain?
No, I don't use lumbar drainage. Before the opening the dura, as I showed, maybe I can show again. Can I? I always open the cisterna magna with a different show. I use a dual incision parallel to the transverse sinus, and a curvilinear incision, and another incision at the bottom of the craniotomy to release CSF from cisterna magna. for 1 centimeter dual incision. Because of this, I don't need lumbar drainage to release CSF, because before starting the operation, I release CSF from the sternum magna via another dual incision.
Okay, we can go to another question. Dr. Musa Chirac from Istanbul is writing, I would like to tell, and thanks to Dr. Güngör, excellent presentation and excellent cases. I would like to ask why he used one-sided craniotomy.
Yeah. Why? Because, as I said, when you go the midline, most of structures get an obstacle for you, and if you go to the midline, there is well-known bridging veins. When without sacrificing these veins, you couldn't reach the pineal region. Because of this, I always use the paramedian and lateral approach to preserve these veins and the better exposure.
Okay. Progress. Another comments. Yeah. Woman neurosurgeon Madonna Hobadze writes that my sincere gratitude and admiration for Professor Güngör and his team. Çok teşekkür ederim. She's writing neurosurgeon from Georgia, as I mentioned. Other, yeah, what doctor? Can you repeat?
So I am reading the questions.
Yeah. Questions. Yes, one question is here. Gürkan is writing, thanks for the nice presentation. How do you proceed when there's any bleeding as in tentorium?
Okay.
And he's from Atatürk Training and Research Hospital.
While dissecting the bridging veins, I put the hemostatic agent while if there is a bleed from them. And also we use bipolar coagulation while open the tentorium for transtentorial approach. Before the opening tentorium, you can use Doppler to avoid to make an injury to the venous legs, tentorial legs.
Okay. Other questions? 1 minute. Yes, one question. Yasser Özgunduz is writing, great and inspiring presentation. I'm curious if a fourth nerve, I mean cranial nerve, is under risk during cut of tentorium. If it is, how possible to avoid? Aksaray Training and Research Hospital is from.
Yes, when you are cutting the tentorium, because the fourth nerve going just under the tentorium, but most of the case it is easy to define the fourth nerve because before cutting the tentorium, you must see the end of the tentorium, then fourth nerve, then start to cut the tentorium from posterior to the anterior.
Okay. Another question from Dr. Harshad Pareh. Excellent presentation. What is your experience of contralateral approach?
Yes, I use this approach, but not most of the case. Most of the case, I use the ipsilateral approach, but if there is a transverse sinus dominancy, I prefer the contralateral side to approach if it is possible. And also there's some regions, for example, third ventricular surface of the thalamus can be reached easier with contralateral approach. It depends on the case.
Okay, Anthony is writing, for pulvinar lesions, do you prefer occipital interhemispheric approach or supracerebellar infratentorial approach? And don't you find supracerebellar approach a long route?
Yes. As I said before at the beginning of the my presentation, you can use both approach with the occipital interhemispheric approach or supracerebellar infratentorial approach for pineal and most of these lesions. I prefer supracerebellar approach because in supracerebellar approach you don't retract any eloquent area. But in occipital interhemispheric approach, sometimes it's needed to retract and the visual areas can be affected. Yes, it is a bit long route, but you can reach and remove most of the tumors with supracerebellar approach.
Thanks for your answer, doctor. And another question waiting from
we have one article about preserving the visual areas in posterior occipital interhemispheric approach because it is complication, some of the complication of the occipital interhemispheric approach.
And Harshal Parekh regarding that is asking what position you use for supracerebellar approach and occipital interhemispheric.
Yeah, I use for supracerebellar approach as I showed before, lateral dynamic lateral semi-sitting position, and lastly we use semi-lateral semi-sitting position to can change the angle of the table and avoid venous embolism and postoperative pneumocephalus. But any approach can be used. Any approach has advantage and disadvantage. You can choose your approach. And for occipital interhemispheric approach, it is written for occipital interhemispheric approach, I am using a prone oblique position and ipsiside down, or also use for using gravity.
Thanks for your answer, doctor. Again, Deniz Nerdenian is asking, greeting from Germany, what tricks of the trade would you mention if the arachnoid of the pineal region is thicker than usual? Because as we know, it is pretty thick at this region. Thank you.
Yeah, you can use a sharp dissection and cut these arachnoid bands. If you have any suspicion, you can use Doppler before cutting these attachments. Also, as the Dennis said, it is a thicker arachnoid.
It's thicker. Yeah.
Yes, thicker arachnoid bands in pineal region, but also the way venous system is stronger than the other areas of the brain. I don't know why, but I didn't see any venous injury in this approach.
Thanks again. Ahmet Özak is asking, thank you for your outstanding presentation. For the supracerebellar approach, semi-sitting position is suitable to reach deeper structures. What do you think about concorde position?
Yes, you use concorde position, but as I showed in my slide, any position has their advantage and disadvantage. In concorde position, you don't see the venous embolism, but you couldn't lose the gravity, and you must use an aspirator to evacuate all hematoma. But in semi-sitting position, you can use gravity, and without retraction, you can reach all structures, and blood go outside without any effort. but it depends on your experiment and your anesthesiology team.
Yes, thanks again. Dr. Harshad Parekh is asking, do you use navigation?
Yes, most of the case, if I can use navigation, I use navigation, ultrasound, neuromonitorization, and ultrasonic aspirator. I can use whatever I can.
I will ask from my side, how often you use neurophysiological monitoring?
Neurophysiological
You
monitor.
have the specialist and you are, yeah, you are using so often or not
Yes,
always?
always use in brainstem pathologies and thalamic pathologies. I always use monitorization.
Thanks again. If you have any other questions, anyone, you can ask now. Otherwise, I think that we can thank Doctor a lot for such impressive presentation and answering a lot of questions what we asked. Anyone? And Dr. Hassan, if you have any comments, you can go through.
I also want to thank Professor Güngör for this excellent presentation, excellent lecture. And I want to thank everyone who joined us today, this evening. And I want to give some information about the meeting. There were 82 people joined the presentation at most. Good number. Thank you so much for everyone.
I want to thank again all our audience and thanks for invitation.
Thank you.
I hope you enjoy.
Thanks again. It was great.